بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the second talk in the series of spinal imaging, and as I have said before, we will discuss inshallah the degenerative diseases of the spine, which will be divided into two parts. Part 1 and part 2 will be after that. You know that the degenerative diseases of the spine are also known as spondylosis or spondylodegenerative diseases that can be evaluated by the plain X-ray, the CT scan, and the MRI. And I have explained in the part of the normal anatomy how to perform the CT scan of the spine, and also I have mentioned the needs for contrast injection, and I said that the contrast injection in the CT and MRI is usually directed for the whenever the inflammation or neoplastic lesions are suspected, also in cases of postoperative lumbar spine. Contrast injection is not usually needed for evaluation of disc pathology in cases of spinal trauma and some cases of congenital anomalies. And you know we have four types of MR machines: the closed magnet, the open magnet, and this is an example of the closed magnet, and the extremity magnet, and also the dynamic magnet, which is an important tool for evaluation of the spine pre and post-operative. And actually you need to detect the real changes in the spine, and you have to image the patient while there is some axial load on the vertebral column. Then in such a case where you can see that this image is obtained while the patient is lying down, and this patient had performed an operation in the lower part of the spine, and you can see that no significant abnormality is detected here. The operative bed is good, but when the patient was examined while he is standing, then you can see that there is significant spinal instability at L3-4 level, with marked narrowing of the spinal canal and displacement of the vertebra. Then degenerative diseases of the spine are listed under these headings: the spinal canal stenosis, disc lesions, bone marrow pathology, ligamentous pathology, osseous changes, spondylolysis or spinal instability, and finally the changes in the spinal cord. And actually, under each of these topics, there are three subdivisions. For example, the spinal canal stenosis has three types: the congenital type, the developmental type, and the acquired type, and so on. In the first part of this talk about the degenerative diseases of the spine, we will handle only the first two items, which are the spinal canal stenosis and the evaluation of disc lesions. And you remember from the anatomy that we used to measure the sagittal diameter of the lumbar spinal canal at the level of the pedicle, where the canal is totally closed or there is no side openings, and this should be done in the bone window images, since the spinal canal is a bony structure. And the normal diameter of the spinal canal is 1.3 centimeter or 13 millimeter. If the canal is lower than 13 millimeter, then you can say that this is a stenotic canal. And this type of stenosis is known as idiopathic type of spinal canal stenosis. The second type is known as the developmental spinal canal stenosis. In this type, if you measure the diameter of the spinal canal, it may be within normal. But if you look carefully inside the spinal canal, and you can see that the cecal sac is markedly compressed and flattened because the spinal canal is narrow. And the cause of narrowing is threefold. Number one, these are the ligamenta flava, which are markedly hypertrophied articular facets and hypertrophied short laminae. As you can see, this is the lamina, which in this type of stenosis will be thick, and the interlaminar angle will be acute. Then the developmental type of the spinal canal stenosis, as you can see, this is the normal spinal canal, and this is the developmental type of spinal canal stenosis, where you can see that the articular facet is large and the lamina is short. And of course, if you can see the soft tissues, you will also see that the ligamenta flava are also hypertrophied. This will result in significant narrowing of the lumen, or the space inside the spinal canal. And this is two cases with CT myelography of the lumbar spine, and to appreciate the difference between the normal canal and the developmentally narrowed spinal canal. In the normal canal, you can see that the lamina is of usual or normal thickness, and the interlaminar angle is obtuse. The articular facets are of normal size, and also the ligamenta flava are within normal limits. But here, look in this example, and you can see the articular facet is markedly hypertrophied. The lamina is very thick and very short. The interlaminar angle is acute, and the ligamentum flavum is hypertrophied. Then you can see ligamenta flava in the axial images. They are lying along the inner aspect of the lamina. This is the site of the ligamenta flava. And also you can see these ligamenta flava in the sagittal images in the scans that are obtained slightly off the midline, because in the midline you cannot see the ligamentum flavum, but a little bit to the left and a little bit to the right you can see. And this is the normal appearance of the ligamentum flavum. This ligamentum flavum is hypertrophied, and this one is markedly hypertrophied, and this one also is hypertrophied. And this is the difference between normal ligamentum flavum, which looks like a thread like structure lying against the inner aspect of the lamina, and this is the hypertrophied ligamentum flavum, which is much more thicker. This is an extreme example of how can extensive hypertrophy of the ligamenta flava affect the diameter of the spinal canal. Actually, if you measure the diameter of the spinal canal, it may be normal, but the cecal sac is markedly compressed and flattened against the posterior border of the vertebra, and the most of the spinal canal is occupied by this very dark structure representing the hypertrophied ligamenta flava. Then if you look to this sagittal T1 weighted image, then you can see this is the normal size and appearance of the ligamentum flavum, which is located along the posterior aspect of the spinal canal. While here you can appreciate the marked thickening and the hypertrophy of the ligamenta flava with consequent encroachment on the diameter of the spinal canal. And the spinal canal stenosis, if you measure the diameter and if it is less than 13 millimeter, then you are dealing with idiopathic type of spinal canal stenosis. And also, if you see that the laminae are short and hypertrophied, the interlaminar angle is acute, the ligamenta flava are hypertrophied, and this is the developmental type of spinal canal stenosis. Both types can exist in the same patient. Also, in this particular example, you can see a large diffuse posterior disc bulge, also encroaching on the spinal canal. Then you have the three types of spinal canal stenosis in a single case: idiopathic, developmental, and acquired. This is the normal appearance of the spinal canal. You can see the ligamentum flavum, and you can see that the cecal sac is good. There is adequate epidural fat surrounding the cecal. An idiopathic type of the spinal canal stenosis, meaning that the sagittal diameter of the spinal canal is less than 13 millimeters. Then this is the idiopathic type where the sagittal diameter is less than 1.3 centimeter, and this is the developmental type where the lamina are short and thick, the ligamentum flavum is markedly hypertrophied, the articular facets are hypertrophied, the cecal sac is significantly compressed within the spinal canal. And these are the three examples to show the difference between the normal canal, where the coda equina nerve roots are surrounded by adequate CSF along the cecal sac, and this is the narrowed canal, where you can see that the coda equina are running in a very tight canal with little amount of CSF surrounding the coda equina nerve roots. And this is because of the hypertrophy of the ligamenta flava encroaching on the posterior aspect of the spinal canal, as well as multiple disc lesions encroaching on the anterior aspect of the spinal canal. This type of the spinal canal is what we call the capacious spinal canal, where the anteroposterior diameter is 2 centimeters or more. And you remember, this type of the canal is one of the causes of low back pain because of the ectasia of the cecal sac, which is not adequately supported by bone. This is an example of capacious lumbar spinal canal, where you can see that the diameter is too much increased. And you see here there is a ectasia of the cecal sac with the posterior part of the ceca is not adequately supported by bone. And in the cervical spine, as I have said before, you should see the spinal cord, and you should see anterior to the cord and posterior to the cord there is CSF space. And if you look to this example, and you can see that the CSF space anterior to the cord is obliterated here, and also the posterior CSF space is also obliterated over this segment, which extends from the level of C3-4 disc down to C6-7 disc. Then we have three types of or 3 degrees of spinal canal stenosis in the cervical region. The first degree, or mild cervical spinal canal stenosis, where you can see the CSF space along one side of the cord, either anterior or posterior, with obliteration of the second CSF space. In this example, you can see obliteration of the posterior CSF space, but the anterior space is good. The moderate degree of spinal canal stenosis, there is obliteration of the CSF space anterior and posterior to the spinal cord. In the severe type of spinal canal stenosis, you see obliteration of the CSF space on both sides of the cord, together with reduction of the cord caliber. This significant compression of the spinal cord compared to the segment above and the segment below. Then this is a mild degree of cervical spinal canal stenosis, where there is the CSF space along one side or one aspect of the cord. And this is a mild degree of spinal canal stenosis with obliteration of the CSF space along the anterior and posterior aspects of the cord. And this is normal spinal canal by CT myelography, and you can see the shadow of the spinal cord surrounded by the injected contrast material, while here is an example of severe spinal canal stenosis. The spinal cord caliber here is good, but while going down, you can see that there is marked reduction of the cord caliber in this particular segment of the cervical spine. And this is the severe type of cervical spinal canal stenosis with significant reduction of the cord caliber in the stenotic segment compared to the normal caliber above and below the site of the lesion. Then we have three types of spinal canal stenosis. The idiopathic type, where the sagittal diameter of the spinal canal is less than 13 millimeter. The developmental type, where the canal is the space inside the canal is reduced due to hypertrophy of the ligamenta flava, hypertrophy of the laminae, and hypertrophy of the articular facets. Then the acquired spinal canal stenosis will be secondary to disc bulge, herniation, osteophytes, and so on. Then we came to the issue of disc lesions, and we have three types: disc degeneration, disc bulge, and disc herniation or disc extrusion. Herniation and extrusion are the same. Then you remember that the normal appearance of the lumbar disc is concave posteriorly. You see the concavity of the lumbar disc posterior aspect, and this is considered normal. And also the concavity will be reduced by age, but you can see that this concavity is still present. This is good, and this is good also. Then in the cervical spine, normally you should not see any disc material posterior to the bony border in the spinal canal. But if you see a disc material beyond the bony border of the vertebra, then you know that this disc is abnormal. In the MRI, you should see that the disc, the intervertebral discs are of low signal in the T1, high signal in the T2. They are maintaining their heights, and there is no extension of the disc beyond the posterior edge of the vertebra above or the vertebra below inside of the spinal canal. The disc is flush. The posterior edge of the disc is flush with the posterior border of the vertebra above and below. The same applies for the cervical discs, and the discs are bright in the T2 weighted image. The posterior edge of the disc should not exceed the posterior border of the vertebra above or below. Then we start by the first lesion in the disc group, which is the disc degeneration. And you know that the disc is composed of two main parts: the annulus fibrosus and the nucleus bulbosus. Annulus fibrosus is made of fibrous tissue surrounding the nucleus, which contains water made of cartilage. Then starting the process of disc degeneration will be by loss of water from the nucleus, and this is only detected by MRI. Then after the nucleus loses the water content, then it will lose its height. Then loss of height will lead to narrowing of the disc space, and this narrowing of the disc space can be seen by X-ray, by CT, and by MRI. After that, there is degeneration of the nucleus with the development of intradiscal air, which is known as vacuum phenomenon. And this vacuum phenomenon can be seen also by X-ray, by CT, and by MRI. And the first stage of disc degeneration is loss of water, and in the T2 weighted image, normally you will see the disc of bright signal, but if you see that the disc is black, then you know that the disc has lost its water content. And this is a degenerated disc L4-5, and this is also a degenerated disc L5-S1. Then loss of height can be seen by X-ray. This is the normal height of L3-4 disc, and this is reduced L4-5, and this is reduced L5-S1 disc spaces. This can be also appreciated by MRI. This is normal L3-4, normal L4-5, and this L5S1 disc is degenerated. There is loss of signal, there is loss of height, and there is extension of the disc inside the spinal canal, which means that it is developing or developed bulge or herniation. Then the development of intradiscal air, which is known as vacuum phenomena, means that there is advanced degeneration. This can be seen by the plain X-ray, and it can be also seen by MRI, by CT. As you can see here, the disc is the air is well appreciated by CT, especially if it is small, like this one, and you see minute air loculus in this disc space. Also another air loculus in the L45, and more air at L5S1. This is a sagittal reconstructed CT image of the lumbar spine. And this is the plain X-ray showing minute air here and there and there. This is known as the vacuum phenomenon. In MRI, it may be difficult to detect air within the disc because the disc will lose its water first. Then the disc will be of black signal in the T1 and T2 weighted images, and air is also of black signal in the T1 and T2 weighted images. But you can easily appreciate the presence of air here and there compared to the discs above. These discs do not contain air, while here and there, and you can see this very dark signal is due to the presence of air within the disc substance. Then if you look to the sagittal T1 weighted image and T2 weighted image, you can appreciate that L34 disc is degenerated and extending inside the spinal canal. L45 is degenerated and extending also inside the spinal canal. L5S1 is good, and L23 is also good. Then how to discriminate between disc bulge and disc herniation or disc extrusion? You know that the posterior edge of the lumbar intervertebral disc is concave normally. Then disc bulge means that the annulus is weak but it is intact, while disc herniation means that there is a tear in the annulus with extension of the nucleus outside the confinement of the annulus. Then, by definition, disc bulge is a diffuse pathology. Disc herniation is a focal pathology. Diffuse meaning that there is all around bulging edge of the disc itself. But you know that the anterior edge of the disc is not of importance. But what's important for us is the posterior edge of the disc. Then if you see that the posterior edge of the disc is uniformly bulging from left to right, and you call this disc bulge. But if the pathology is focal, either to the right or to the left or in the midline, and this is known as disc herniation. And disc herniation in this case is to the right side. If it is to the left, it will be left posterolateral disc herniation. If it is in the midline, we call it central posterior disc herniation. Then in this example, you see that there is diffuse bulge of the edge of the disc from left to right. Then you are dealing with disc bulge, and this is also a disc bulge with diffuse bulging of the edge from left to right. Okay, and if you look carefully to this MR example, and you see that L45 and L5S1 discs are degenerated and they are extending inside the spinal canal, and I want to know if this is bulge or herniation, then I go to the axial image. In the axial image at L45, I see that the edge of the disc is diffusely bulging from left to right, then this is bulge. At the level of L5S1, the posterior edge of the disc is also diffusely bulging from left to right, and this is disc bulge. Then you see here L34 and L45 are degenerated with loss of signal, loss of height at L45, They are extending inside the spinal canal, and I want to know if this is bulge or herniation. I go to the axial, then I can see the edge of the disc is bulging from left to right, and this is disc bulge. In the cervical spine, and this is C2, 3, 4, 5, 6. C4, 5 and C5, 6 are extending slightly inside the spinal canal. At C4, 5, you can see the edge of the disc is diffusely bulging from left to right, and this is disc bulge. At C5, 6, and you can see also the edge of the disc is bulging from left to right, but it is more on the left side, meaning that the annulus is more weak on the left side, and we call this diffuse posterior and left posterolateral disc bulge. And if the annulus is going to be torn, after that, this will be the site of the tear. Then for disc herniation or extrusion, the annulus should be torn, and there are 5 sites for annulus tear. The first one is in the middle, which is known as central disc herniation. The second one is a little bit off the midline, and this is known as paracentral, or sometimes is known as subarticular. The third one is in the foramen, so that it's called foraminal disc herniation. And the fourth one is outside the foramen, but it still has relation to the nerve root, and this is known as extraforaminal or lateral disc herniation. Then the anterior disc herniation is, of course, of little significance, as you know, and it corresponds to this yellow color. Then here is an example. You see this is the annulus and this is the nucleus. The annulus is torn on the left side, and the nucleus is coming out to compress the corresponding nerve root. This is the MR examination, and you see that the disc is focal, and this disc is to the left side. This is the cecal sac containing CSF of low signal, meaning that this is T1 weighted image. Then the diagnosis here is left posterolateral disc herniation, and this is right posterolateral disc herniation. The disc is massive, and you see the main bulk of the disc is to the right side. It is in the midline and also to the right side. We may call this central posterior and right posterolateral disc herniation or extrusion. And this is the difference between disc bulge, which is a diffuse pathology involving the whole edge of the disc from left to right, and disc herniation or extrusion, which is a focal pathology that may be on the left or on the right or in the midline. Then if you look to this example by MRI, and you see L45 is degenerated and is extending inside the spinal canal. I want to know if this is herniation or bulge. I go to the axial image, then I can see that the disc is focal and most of the disc is towards the right side. Then I call this right posterolateral disc herniation. The definition of disc protrusion means that there is tear of the inner fibers of the annulus, but the outer fibers of the annulus are still intact. And if there is full thickness tear of the annulus, then you got disc herniation or extrusion. But at this stage where there is some of the annular fibers are still intact, and you call this disc protrusion. But actually we cannot see the annulus by CT or by MRI. Then we agreed about a way to diagnose this disc protrusion, and this means that we can measure the disc. How to measure the disc? We measure the disc height from its base to its apex. If this distance is within 2 millimeters, then you can assume that the outer fibers of the annulus are not yet torn. Then you can call this disc protrusion. Then look at this disc at C23 and C34. There is minimal extension inside the spinal canal, and in the axial image you can see. Actually, by time you don't need to measure the disc, but you can appreciate if this is protrusion or herniation. Then disc protrusion is a focal lesion that usually do not exceed 2 millimeter in height. And there is another way to assess for disc protrusion is that if you look to this disc and you know that this disc is extending inside the spinal canal, it may be bulge or herniation. Then you go to the axial image and you see that the disc is focal, meaning that it may be protrusion or may be herniation. If it is more than 2 millimeter, it will be herniation. If it is less than 2 millimeter, it will be protrusion. And from the sagittal image, you can decide whether it is protrusion or herniation. If the disc does not exceed the vertebral end plate above or below, you can assume that this is disc protrusion. Look at this example. You see here a central disc, and this disc by measurements is more than 2 millimeter, and you consider it disc herniation. Then, how can you differentiate between herniation and protrusion? You can measure. And there is a third way. You measure the base of the disc against the height of the disc. If the base is more than the height, and you assume that this is protrusion. If the height is more than the base, you can assume that this is herniation. Look at this example. And you see here, if you measure the base against the height, the base is more than the height. Then this means that this disc is protrusion by definition. But if you go to the sagittal image and you can see that the disc is exceeding the vertebral end plate above and below, and by definition here, the disc should be herniation or extrusion, and this was confirmed by surgery. Then let's go back to settle down facts. If you see a disc extending inside the spinal canal, and this is CT, and you call this disc, which may be bulge or herniation or protrusion, then you go to the axial image. If the disc is focal, it will be one of two, either protrusion or herniation. If the disc height is within 2 millimeter, you consider it protrusion. If it is more, you consider it herniation. But if you see that the disc is extending up or down beyond the limits of the vertebral end plate above or below, and you call this herniation for sure, then you can diagnose this herniation from the sagittal images, and also you can diagnose this herniation from the axial images. This is the new term which goes for the disc protrusion, and you see that the height of the disc is small. But what is of interest for us now is the base of the protrusion, whether it is narrow or whether it is wide, because you have two main issues in the literature now, what we call focal disc protrusion or broad base disc protrusion. Then let's go back for the issue of herniation or extrusion and protrusion. If you look here in this cervical spine, and you see there is a disc which is extending inside the spinal canal. The disc is exceeding the vertebral end plate of the vertebra below. Then by definition, this disc should be herniation. And if you go here and you see that this disc is focal and it is more to the right side, and it has a very narrow base and a height which is more than the base, denoting that this is the actual disc herniation. Then what do you expect from this example? L4-5 disc, this is L5 which is sacralized. L4-5 disc is extending inside the spinal canal, it is degenerative. If we apply the previously mentioned rules, we should say that this is disc herniation. And in the axial images, we can see that this is disc herniation on the left side. And you need the axial images to know which side the disc is herniating, to the left, to the right, or in the midline. Then, disc herniation into the foramen can be diagnosed in the sagittal and in the axial images. In the axial images, you can see disc material obliterating the foramen. In the sagittal images, normally you see the foramen containing fat and the nerve root is in the middle. This is normal foramen, and this is normal foramen, and this is not normal foramen. The foramen is totally occupied by the disc material, which is seen here, and this is known as foraminal disc herniation. Extraforaminal or lateral disc herniation is the herniated disc outside the foramen, but it is compressing the nerve root. Then, the same rule in the sagittal image, you see the foramen containing fat with the nerve root inside, the foramen containing fat with nerve root inside, the foramen is totally obliterated by this herniating disc material. Okay. And we have agreed that for disc herniation to occur, there should be a full thickness tear of the annulus. If the annulus is partially torn, the outer fibers are still intact, and you call this disc protrusion. Then after herniation, the disc can migrate either down or above or upward, either downward or upward. And after migration, the apex of the disc may be separated from the original disc, and you got what's known as sequestration. Then, if you look here and you see this is the cervical disc at C4-5 level, and you can see the disc is extending inside the spinal canal and slightly going up. And this is the disc which is central disc herniation with cephalic migration, let us say. Then you need the axial images in order to decide the direction of the disc, whether left or right. And you can also decide the direction of the disc, whether left or right, from the sagittal images, provided that you have the full series of the sagittal images. And this is an example. This is the midline image where the cord and the conus are seen. And this is the image to the left, and this is the image to the right. And you know that all MR machines are cutting the sagittal images starting from the left going to the right. Then the first image on the film will be the left side of the patient. The last image on the film will be the right side of the patient. Then in the midline image, you can see that there is disc herniation at L5S1. If you go to the left and the disc is smaller, if you go to the right and the disc is larger, then this disc will be herniation to the right side. Look at the axial image and you see that the disc is herniation to the right side. But if you see that the disc in the midline is almost similar to that on the left and that on the right, and you know that this is diffuse posterior disc bulge. Look at another example. This L5S1, this is the midline image, left image, right image. The disc is getting larger on the right side, and this means that the disc is right posterolateral disc herniation, and you can see this is the disc which is on the right side. And disc migration, the direction of migration of the disc depends on the site of the annular tear. If the annulus is torn from its inferior aspect, the disc will migrate down. If the annulus is torn from its superior aspect, the disc will migrate up. If the annulus is torn at its mid portion, the disc will continue inside the spinal canal, then will grow down. Then, before the era of MRI, we used to diagnose disc migration as follows. In the axial image by CT, you can see disc material on the left side. This is left posterolateral disc herniation. The second section is still you can see the disc. The third section is still you can see the disc. The fourth section is still you can see the disc. then you know that this disc is herniation and is migrating caudally. But by MR, you can see from the sagittal image that this L45 disc is herniating and is migrating cranially, as you can see here. Then you want to know if this disc is to the left or to the right, and you go to the axial images and you realize that the disc is to the left side, as you can see here. Then what happens if the distal fragment of the disc has been separated from the rest of the disc substance, and this is known as disc sequestration. And you got a disc fragment within the spinal canal at a relatively higher or lower level from the original disc. And this is a good example. Here you see L45 disc is herniating and migrating towards the cranium, and you see a big disc fragment that has been separated from it, and this is disc sequestration, which is of course to the left side, as you can see here. This is also another example, and you see a disc fragment here, which is also well seen here, and this disc herniation, cephalic migration, and sequestration. Then this is a very good or very important issue you should know, which is known as disc herniation and granulation. You know that the nucleus bulbosus is very irritant to the epidural space or fat. Then if the annulus is torn, then the nucleus is in contact with the epidural space. It will create a reactive, it will create great irritation that will result in reactive granulation tissue, which will surround the area of disc herniation. And of course, you can easily appreciate the difference between the disc and the associated granulation tissue. But in the T1 weighted image, you cannot easily discriminate between the disc and the reactive granulation tissue, and you will assume that this is massive disc herniation, which is not the case, as confirmed by the axial T2 weighted images, where the disc material will be dark because it is degenerated, and the granulation tissue will be somewhat bright because it contains water. Then, if there is any doubt, you can inject contrast medium. The disc, of course, will not enhance, while the granulation tissue will enhance. And this is an example. You can see here that L45 disc is herniating and is migrating caudally. But this is not the actual size of the disc. In the post-contrast image, and you can see there is enhancement of the epidural space, which represents the granulation tissue surrounding this herniating disc. And in the axial image, this is T1 before contrast and T1 after contrast and T2. In the T1 post contrast, you can see enhancement representing the granulation tissue and the disc substance inside this granulation tissue. And also here it is easy in the T2 weighted image to separate between the herniating disc and the associated granulation tissue. Of course, this diagnosis is very important, so that you may say to the surgeon, don't operate. This is not a massive disc herniation. This is just a small disc herniation and is surrounded by a granulation tissue, which will regress if the patient is adequately managed conservatively. هذا وبالله التوفيق والحمد لله رب العالمين.